All right. We're going to talk a little bit about diabetic emergencies as well as altered mental status. And I divide this into two lectures because it's a quite lengthy chapter. So we'll talk first about some generalization about altered mental status and some general assessment issues. Then we'll talk about diabetic emergencies. And the second part will be other causes of altered mental status besides diabetes. Now, when we think about consciousness, where in the brain is that regulated? And that is in the brainstem. A portion of the brainstem, known as the reticular activating system, is responsible for your consciousness, for you staying awake, for you paying attention. And when the RAS is not being stimulated, you sleep. Most of us like a room comfortable, dark, without noise, so that we're not stimulating that RAS. And that allows us to go to sleep. The RAS then is the part of the brain that keeps the person alert and oriented. In order for the RAS to function, as with any tissue, you need oxygen, you need glucose, you need water. So the brain does not function well, or any part of the brain does not function well, when it isn't receiving an adequate supply of oxygen. Unlike other tissue, the brain does not have the ability to store oxygen, and it uses the oxygen that it has quite quickly. We're all taught in basic life support that brain cells begin to die within 4 to 6 minutes without any sort of oxygen supply, where your arms and legs can go up to 4 to 6 hours without any oxygen supply before those tissues start to deteriorate. The brain also needs a tremendous amount of sugar in order to fuel all those functions that occur inside the brain. It also needs water. It needs to be hydrated. The brain does not function when it's dry. There's a variety of different things that will cause an altered mental status, and when we talk about altered mental status, it means a lot of different things to different people. To me, we all should know who we are, where we are, a general idea of time and what happened. If I don't know those things, then I would say that my mental status is altered. People may not remember their birth date. They may not remember who the president is, or they may not remember even what day it is. For some people, those things aren't important things to worry about. But everybody should know who you are, where you are, a general idea of time and what happened. So, causes of altered mental status include deficiencies in oxygen, as we mentioned, deficiencies in sugar, deficiencies in water. So a dehydrated brain is not going to function. A hypoglycemic brain is not going to function, nor is a hypoxic brain. In addition to those things, trauma from head injury will cause an altered mental status. Infections like an encephalitis or a meningitis could cause altered mental status. All kinds of chemical toxins that are in our environment, if we breathe them in, may cause an altered mental status. Altered mental status may be caused by a primary problem inside the head, like a stroke, and we'll talk a bit about a stroke in the second part of the lecture. It may also be from a problem outside the head, like hypoxia, like hypoglycemia, like dehydration. Those things all occur outside the body, but do affect the level of consciousness. Now, patients with altered mental status can be dangerous to responders because they may be altered to the point where If they're not sure of their environment, they could be very frightened. And because they are frightened and not aware of their surroundings, they may become violent. So always consider your safety and the safety of your team before approaching any patient with an altered mental status. Patients with altered mental status may also be under the influence of drugs, which may make them at greater increase of violence as well. So make sure that you have law enforcement present. Now, syncope. Syncope is when somebody passes out. Syncope is a simple faint. Typically, when a person has syncope, it's the result of the blood vessels dilating while you're standing. The blood pools down into your lower extremities and doesn't get to your brain. The brain doesn't get a good blood supply and tells you to lie flat. If you lie flat, then the blood makes its way back up to the brain and you wake up. So syncope usually is self-correcting when you lie them flat. And once they lie flat, and once the issue with their dilated vessels resolves, then the patient is just fine. If syncope lasts more than several minutes, it may not be just from the vessels dilating. It may be an arrhythmia. It may be some other problem that requires our assessment. Now, when we do a primary assessment, the whole purpose of the primary assessment is to find life threats. And hypoxia is one of the most common causes of altered mental status. So you should always consider the possibility of hypoxia in a patient with altered mental status. And hypoxia is often caused by some sort of problem with the airway or breathing. During that primary assessment, you identify life threats, and the two most immediate threats to life are hypoxia from not breathing and blood loss. You want to consider oxygen administration, particularly in patients whose pulse oximetry is low, if there's any cyanosis, if they're complaining of any shortness of breath. Be alert to the need for positioning and suctioning if the patient requires it, or if their mental status worsens. Most often, patients with altered mental status will have lying flat. And if they get sick and they vomit and they're lying flat on their back, they're at a greater risk of aspiration. So if you've got that patient with an altered mental status, and there's no indication of spinal cord injury or trauma, there's no reason you can't put them into the recovery position or roll them up onto their left side. And then determine their baseline mental status. What is normal for this patient? Obviously, you're going to have patients that have had previous strokes, patients that have developmental disabilities, whose mental status may always be altered. So try to determine what the baseline mental status is for these patients. Examine the patient who is exhibiting new or unusual behavior, and even slightly altered mental status can indicate a serious underlying issue. So we should take it seriously and do the assessment. Remember your secondary assessment, you've already ruled out your life threats. You've gone through your airway, your breathing, and your circulation. You've determined the priority of the patient, and you're moving on to a good set of vital signs, a good head-to-toe exam to try to figure out what may be causing this patient's altered mental status. So doing that physical exam, getting that sample history may give you the information that you need to determine why this patient's mental status is altered. Obviously, a person with an altered mental status isn't going to be a good historian, so you may have to interview family members or bystanders who are present when you arrive. Family and bystanders certainly can give you some good information. The patient's medications may point to a relevant medical history that would cause altered mental status as well. If the patient has diabetes, diabetes certainly is another cause for altered mental status when sugars are too low or sugars are too high. So look for medicines that they may take that would indicate they're diabetic. Now, as far as children go, the younger children certainly may not be able to answer your questions in the same manner as adults, so their mental status is often difficult to establish. So you want to ask the parents or the caregivers, are they acting differently than normal? We also can use the mnemonic AVPU when assessing the mental status of children. Are they awake? And if they're not awake, their eyes are closed, do they open to voice? And if they don't open to voice, do they open to pain? And if they don't open to pain, are they unresponsive? So that's a quick and easy way to establish the mental status in children. So we're going to talk first about diabetes because as an endocrine emergency, as a altered mental status emergency, diabetes is high on the list. We know that sugar, or glucose, is the body's basic source of energy. Your body requires glucose in order to remain alive and in order to create energy. The glucose molecule is large, and it combines with oxygen in the cell to make ATP, adenosine triphosphate, which is the energy that your cell uses to live. But because the molecule is large, it won't pass into the cell by itself. It needs some help to move from the blood into the cell, and it uses insulin to do that. Your pancreas, through the beta cells of the pancreas, secrete insulin out the common duct into the bloodstream. The pancreas secretes insulin anytime your blood glucose rises. So after you eat a meal, your pancreas is going to secrete insulin into your bloodstream. After you drink a soda, your pancreas is going to secrete insulin into the bloodstream. And it's the insulin then that helps move that blood sugar that's in your blood, or the sugar that's in your blood, into the cells so that they can make energy. Without insulin, your blood glucose will get dangerously high, and we'll talk about problems that we can see in patients with high blood sugar or hyperglycemia. Insulin is produced by the pancreas. Insulin binds to receptor sites on the cells and allows the large glucose molecule to pass into the cells. Now, your body does an amazing job at balancing your sugar intake with your insulin production in order for you to use glucose effectively as an energy source. But as you take in more and more sugar, there can be a situation over time where you've taken in so many carbohydrates, so many sugar molecules, that the insulin production is ineffective. The pancreas, if you're working it on overtime every day of your life, at some point it's going to stop secreting insulin, or the insulin it does secrete is going to be resistant to your own body. And that's where we develop a certain type of diabetes. Now, the book will talk about two types of diabetes. Diabetes type 1 or diabetes type 2. Now, diabetes type 1 used to be called juvenile diabetes because diabetes type 1 occurred in children. That's how they were diagnosed with their diabetes. In diabetes type 1, the pancreatic cells do not function properly, so insulin is not secreted normally. So there's not enough insulin in your blood to move the sugar into your cells. In patients who suffer from type 1 diabetes, they're often given synthetic insulin to inject, either into their abdomen, into their thigh, but they inject it daily, maybe multiple times a day. And there are many, many different types of synthetic insulins. Insulins that are designed to lower your blood sugar immediately, insulins that are designed to lower your blood sugar over an hour and then taper off, insulins that are designed to just slowly maintain or lower your blood sugar over a period of 24 to 32 hours. So there's a variety of different kinds of insulin as well. Excuse me, I have a cold. Type 2 diabetes, the body's cells fail to utilize the insulin that you have properly. The pancreas is secreting enough insulin, but the body's unable to use it to move glucose into the cells. And this is a condition that often is caused by diet. And you have to control it by diet, exercise, weight loss, and an oral anti-diabetic medication. Now, metformin is probably one of the most common prescribed anti-diabetic medications out there. There's, another handful or so of anti-diabetic medications that a patient may be on, and they all work differently, but the end result is that when you take these oral meds, it helps keep your blood sugar low, or I should say normal, keeps it from rising. Hypoglycemia is a condition, it's a diabetic emergency that comes on suddenly. Hypoglycemia refers to low blood sugar. Now, causes of hypoglycemia is that diabetic who takes too much insulin and then doesn't eat the right amount of food, or the diabetic takes their insulin and doesn't eat at all, or the diabetic takes their insulin and then overexercises or overexerts themselves and burns up more sugar than normal, or the diabetic who vomits and again is not able to eat after taking their insulin, or the diabetic who has an increase in their metabolic rate, like fever or shivering. Certainly fevers consume more energy, require more sugar, and can lower your blood glucose if you don't replace it with sugar. Now, hypoglycemia occurs very rapidly. The patient can be fine 1 minute, and the next minute they could be pale, cool, clammy, sweaty, their heart rate bounding, rapid breathing. They may even appear drunk or stuporous. And if they're not given sugar quickly, then it could lead to seizures and even death. When a patient is hypoglycemic, they're starving their brain cells. Their brain is the largest consumer. Your brain is the largest consumer of the sugar that you take in. It requires lots of it, as we mentioned, in order to function properly. So if it's not getting sugar because the blood sugar is low, then you're going to have an altered mental status. And if you don't correct it quickly, it can lead to unconsciousness and then permanent brain damage. Now, hyperglycemia is high blood sugar. And reasons that people get hyperglycemic is their body's own inability to produce insulin. And that's how many people are diagnosed with diabetes. Their sugar gets way too high. The body responds by trying to pee it out. And because of their constant urination, they become very dehydrated. They become very sick. And they end up in the hospital where they check their blood glucose, and it is extremely elevated. So oftentimes that's how a patient is diagnosed with diabetes, is they end up severely dehydrated, and it's determined that their blood sugar is way too high. Hyperglycemia can also be caused in the diabetic who doesn't take their insulin. Oftentimes, if a diabetic becomes ill, their blood sugar will rise. Anybody who's sick, your blood glucose rises. And the reason that your blood glucose rises when you're sick is you need that additional energy to help fight whatever it is that's making you sick. So in all people, when you get sick, your blood sugar rises. If a diabetic doesn't feel well and their blood sugar rises, they may, like anybody, want to nest. They may want to just lie in bed and eat food that's comfortable to them, like chips and candy and those sort of things. And they may or may not take their insulin, and their blood sugar gets really, really high. Again, the higher your blood sugar rises, the more your body attempts to get rid of that sugar by urinating. So dehydration is a very common problem associated with hyperglycemia. Another problem associated with hyperglycemia is metabolic acidosis, because if the sugar is in the blood and not in the cells can't make energy, and they would normally die. But the cells can function without sugar for a short period of time by metabolizing fat. But the metabolism of fat doesn't create much energy at all and releases a lot of acid. Some causes of hyperglycemia include stress, eating more food, particularly high carbohydrates or foods that are high in sugar. Hyperglycemia takes days or even weeks to develop. Unlike hypoglycemia that comes on within seconds, hyperglycemia takes days or weeks to develop. Patients will they'll get the polys. They'll be polydyspneic. They'll be constantly thirsty. They'll have polyphagia, constantly hungry. They'll have polydipsia, which is thirsty. Polydipsia is thirsty. Polyphagia is constantly hungry, and then they're peeing a lot. And that's the body's way of trying to get rid of the sugar. They may also feel sick to their stomach. They may vomit, which increases their blood sugar if they take oral medications as well as insulin. Again, as I had mentioned, the problem associated with hyperglycemia is profound dehydration. And then the excessive waste products of fat metabolism released into the bloodstream, which leads to a metabolic acidosis that, when it occurs in a diabetic, is called diabetic ketoacidosis, or DKA. Patients in DKA are extremely dehydrated, have excessively high blood sugars, and you may smell the ketones on their breath. A patient in diabetic ketoacidosis is going to have an altered mental status. They're going to be in shock caused by the dehydration. They're also going to be breathing very deep and rapid. It's known as Kussmaul's breathing, and it's their way of trying to get rid of all those acids that are being produced by fat metabolism. Those acids, or ketones, may accumulate to where you can smell them on the patient's breath. Their breath may smell fruity, like fingernail polish remover, unscented fingernail polish remover. In assessing a patient with a diabetic emergency, make sure that the scene is safe. Do your primary assessment to make sure that there aren't any life threats and take care of those. In a diabetic who's unconscious, lying on their back with an increased risk of vomiting, we have to make sure that we protect their airway, make sure they're breathing adequately. Now, a diabetic in hyperglycemic diabetic ketoacidosis is going to be breathing deep and rapid, and we shouldn't confuse that with just hyperventilation that occurs in patients who are anxious. They're breathing deep and rapid for a reason, and we should allow them to continue to do that. In that particular state, diabetic ketoacidosis, they typically don't need any oxygen at all. Their pulse oximetries are going to be good, their lungs are going to be clear, they're getting plenty of oxygen because they're breathing deep and rapid. So it isn't air hunger. It's trying to get rid of the acids inside the body, trying to blow off the elevated CO2 and the elevated H2O in their system from the metabolic acidosis. So you want to, in your secondary assessment in this patient with altered mental status, determine whether or not they've ever had this before. And if it did occur before, what was the diagnosis? You want to evaluate this episode that you're there for. When did it occur? How long did it last? Were there any other associated symptoms? Did they fall or get hurt? Was there any other evidence of trauma? Any interruptions to the episode? Did they have seizures? Were they febrile? Get a good sample history. That may give you your medical and your pertinent past medical history and your medications that may help you determine whether or not this patient is diabetic. You can ask the patient or bystanders. You can look for medic ID bracelets. You can look in the refrigerator or elsewhere to see if you can find some insulin. And if you have the ability to do so, which it is within your scope in the state of Iowa, you want to perform a blood glucose check using a blood glucose monitor. Now, a blood glucose monitor or a blood glucose meter measures the amount of glucose in the bloodstream. It is used by patients who are diabetic in the home, and it certainly can be used by you as an EMT. You want to check the patient's blood glucose if they have a history of diabetes, so you can know whether their sugar is high or their sugar is low. Now, when we measure the blood glucose, any blood glucose less than 60 milligrams per deciliter is called hypoglycemia, and if the patient is awake and can swallow, you want to give them sugar. Any blood glucose less than 50 milligrams per deciliter is also called hypoglycemia. But once we start dipping below 50 is where we see those significant alterations in mental status. You have to take that into account. You have to take into account tolerance. You'll find those patients who have a blood glucose of 40 and they're awake and talking to you and have no problems whatsoever. Well, those are patients who chronically have low blood sugars, and their brain adjusts and learns to function with those low blood glucose levels. If the blood glucose is greater than 140 milligrams per deciliter, that's known as hyperglycemia. And when we get blood sugars greater than 300 for a prolonged time, that's where we start to see dehydration and metabolic acidosis. Now, your blood glucose meter, your glucometer, may display a word instead of a number. It may say high or HI rather than a number. And when you see that on a blood glucometer, that indicates an extremely high blood sugar, usually somewhere over 500 milligrams per deciliter. If the blood glucometer displays low, that usually indicates an extremely low blood sugar level, often less than 15 milligrams per deciliter. And here's a test kit. You got your glucometer, you got your strips, you got an alcohol pad, you got a lancet to prick the finger. Many of these strips require that you touch the drop of blood at the tip of the strip so it can be sucked onto the strip and into the machine to be measured, rather than put a drop of blood on top of the strip. Oftentimes that doesn't work. You just gotta touch the tip of the strip to the blood. It draws it into the strip, takes it down into the machine where it's measured. Now, you can treat a patient with mild hypoglycemia as long as they are able to swallow. Giving them something to eat or giving them liquids, as long as they're awake and can swallow, is fine and is necessary to get their blood sugar up if their blood sugar is low. But in a patient who is not awake and who is unable to swallow, you would never want to give them food or liquids because they may aspirate that. The medication that you would carry and should carry in the truck is oral glucose. In order to give oral glucose, you have to have a patient who has a history of diabetes. A patient has an altered mental status. Their blood glucose is typically less than 60 milligrams per deciliter, and they have to be awake enough to swallow. You want to squeeze the tube directly into the mouth, and the EMT could actually take a little bit of the sugar on a tongue blade and put it between the cheek and gum and let it dissolve there. You may have to do that multiple times in order to administer all the glucose. Once the glucose is given, it'll rapidly go into the bloodstream and the patient should wake up and their altered mental status should go away. So you want to reassess after you administer. You want to reassess their blood sugar level. You want to reassess their level of consciousness, and everything should improve. The thing to keep in mind is that if their level of consciousness does not improve after the administration of sugar, there may be something else going on that is not necessarily sugar related. So you may want to contact Med Control for further orders. The other thing to keep in mind is that once you give a person sugar, their blood sugar will rise. They will wake up, they'll feel better, and as a diabetic, they should know that they need to eat something. If they don't, then you're going to have to encourage them, to eat something. Otherwise, their blood sugar is just going to plummet again. When we look at the onset, just remember that hyperglycemia is slower, while hypoglycemia comes on suddenly. When we look at the skin, a person with hyperglycemic is warm, red, very dry, because they're dehydrated, while a patient with low blood sugar looks like they're in shock. They're pale, they're cool, they're clammy, they have bounding pulses. In a patient with hyperglycemia, you're going to maybe note the smell of acetone on their breath, but not all patients will exhibit this sign, and not all people can smell that acetone even when it's present. So perhaps a better indicator of hyperglycemia when you're looking at breath is a patient who is exhibiting Kussmaul's respirations, very deep, rapid breathing, trying to get rid of those acids from the hyperglycemia. All right, so if you have any questions, you do know how to get a hold of me, and we will end this particular talk here and start back up again shortly with one on altered mental status.